The first question that we will be discussing is meant to establish a picture of what we're talking about when we say palliative care. For many people, their only experience of palliative care is in a major hospital setting. And in many cases, this can be in a ward in a hospital and feel very much like a hospital and really not a hospice care or a warm environment. How reflective is this in terms of what you, the three doctors, define or envision as palliative care? So I'll put the question out there, and if any of the three of you or all three of you would like to address it, please go ahead.
Maybe I'll dive in first. Oh, Thomas, sorry.
Leonie, I know you're going to have an awesome thing. I just want to share this little anecdote that will always stay with me. I was with a dying patient in my nursing home, and one of the doctors who came out of retirement as a palliative care doc and is working in the nursing home with me is a huge asset because he's an older physician and he's a great mentor to me. And I had some issues with somebody's kind of end of life anxiety and agitation, and he came in to see the patient with me after hours, and we had a conversation with a family together. And the dynamic between the two of us is kind of two physicians chatting about what kinds of things we could offer the family. But it was really wonderful to see for us to work as a team and have a family conversation together. This older palliative care doctor and this younger punk like myself trying to have this conversation together as a team was a really wonderful experience to me of palliative care and to a team-based approach, including kind of doctors as colleagues, and so that to me is a little bit more on the ground, not in a hospital ward, but kind of in a nursing home room with family as somebody's dying, having a conversation with them. That was really meaningful to me to be able to have that support from a palliative care colleague. So go ahead, Leonie. I was just wanting to share that story.
Mm-hmm. I think I would just say that it's not really about the place, it's about the tenor of care that's provided to a person. That tenor of care can certainly be enhanced by different settings, but palliative care can be provided in any setting of care and should be provided wherever the patient prefers to be and where their care can be managed. So I don't think one environment is better or worse than another, so long as the team that's surrounding the patient has all of the competencies and skills to provide that expert palliative care. So I think that's what I would say, that it's really about making sure people have the education and the training, and actually communication and having serious illness conversations and providing dignity enhancing care are all skills that can be taught and should be embedded into training programs. So that's how I would respond to that question.
I would also add that as a family doctor, I do home visits. So I really encourage, if it's possible, if the care is in place, as Leonie mentioned, that if people can die at home, it is a wonderful place to be, and that anybody who's considering, say, family medicine or even palliative care, really make home visits part of their practice, because it's a really important service, I think, that we can provide to patients. And I think a lot more people are going to want that in the context of the COVID pandemic, and not wanting to be in facilities is the reality that a lot of people are thinking about. And so I would encourage anybody who's kind of thinking about that to consider doing home visits if they're in family medicine.
Yeah, and I also feel the same way. I mean, we have an amazing palliative care team of nurses, support, PSWs, PTs, OTs, all sorts of care, spiritual care that can be provided not only in the hospital, but at home. And we have two hospices that are fair distance from here, but they are incredible places for people to be looked after. But as Leonie has mentioned, it is absolutely true that it is the providers that are creating the space for the person to have a good experience. And it's not necessarily just the place. We have had many patients who've had great experiences in hospital, and we've also had great experiences at home or in hospices. So I think it's really the environment of the community that's looking after people that's important. And COVID has made it much more difficult because families can't come together, and that is such a difficult situation. I remember when my mother-in-law was in hospital, was in a retirement home, and we'd have to see her at the door. We couldn't even, and she was 101 years old. Like, I mean, we couldn't even talk to her normally. So those sorts of situations are difficult. But in normal situations, we can provide family care within the hospital as well as within the community.
Thank you to all three of you. And then to sort of build on the importance of it being the care and not the location, the next question addresses the fact that there appears to be a lack of palliative care specialists in Canada. Do you think there are ways in which doctors, nurses, and other healthcare professionals can implement aspects of palliative care, even not as palliative care specialists, to help ease this gap? And if so, could you provide some examples of how they might be able to do so?
Sure, I'm going to jump in. So actually, we have a new framework for palliative care in Canada that uses evidence-based approaches to understand how we can better meet the palliative care needs of a large population like Canada when we have many underserved regions and populations, and looking at the need for palliative care in correspondence to the type of training that you need to be able to meet those needs. And the vast majority of people's palliative care needs can be met by their primary care teams who have basic training in palliative care. And we, as I mentioned earlier in my talk, we have a new interdisciplinary palliative care competency framework for Canada, and that it gives competencies for both generalist palliative care and specialist palliative care across all the disciplines: volunteers, PSWs, nursing, social work, physicians. Every member of the care team should have core competencies in basic palliative care. And as I said, that's sufficient to meet the majority of people's needs. And it's actually very few people who need that specialist level palliative care. So our team, as a specialist physician, we really provide kind of an extra layer of support to enhance those primary palliative care teams in doing their good work, which they do so well, and provide that important continuity of care for their patients. And I'm sure Thomas and Paul can speak to you more about that. But I think, we provide education and mentorship and help build capacity. But it's really, only the very complex patients who need to see the specialists more often. So actually the way to improve access to palliative care is to increase everybody's education and comfort level with providing, as I said during my remarks, about a palliative approach to care and how we talk to people, that tenor of care that I talked about, and basic things like approaches to symptom management, having goals of care and serious illness conversations to really understand a person's wishes and help them make a decision and a care plan that's best for them. So I think that's the most important part. And then again, as a compassionate community, it goes beyond the healthcare team, that we all have a role in caring for one another and providing a palliative approach to care. And I really think that that's a really important cultural shift that we need to take in Canada.
I totally agree with you, Dr. Herx. I mean, I've been doing palliative care in town here a long time, and for many years by myself in terms of the sort of consulting palliative care. And it can get very onerous at times because there's so much that has to be done. These days, right now, I'm seeing such a change. We've had 10 of our physicians in town who've volunteered to help out with the palliative care within the community and within the hospital. And I've done teaching with them. We've had now have a sort of a rota for on call, and it just makes it easier for all of us to care for patients. And they get much more experience and dealing with the patients at home, patients in the hospital, and dealing with the palliative care teams of nursing and all the other people that are involved in it. So it's been excellent, and I'm so pleased that palliative care has become such an important part of medical training for all physicians now, so that not only the family doctors can understand what palliative care is all about, but the surgeon can, and the internist and all those other people, because it's important to look at the whole person and not just the disease.
I would just add in that, as a family doctor who is not a consultant, I think a lot comes from experience and just discussion with colleagues, so having some more senior colleagues in our nursing home is one way to do that, where I can discuss with them and ask them some of their approaches to help people who are imminently dying. The other thing I would bring up too is and when we're talking about the importance of community involvement in palliative care, is starting to normalize the dying process. And Leonie, could you put the name of that book by Dr. Steed in the chat box? Because that, I think, has some of the insights from there were really important to me when you were bringing those up. One of the things that I do with my kids, my 4 kids, is I bring them to the nursing home to visit patients, so for Halloween, they get dressed up and come and see my patients. And at Christmas we go, and I brought them to see some patients just to visit that they have formed a bond with. And for them to know that it's not, to kind of be aware of the smells of a nursing home and the kind of wrinkly old soft hugs that they're going to get from some of these people, and just to normalize those things and to not be afraid of them, because sometimes our view of death is so sanitized and so kind of moved to hospitals that people don't realize that death is a normal process. And I think especially from a younger age, children need to be exposed because in this day and age, people often don't die at home. So kids are not seeing people dying at home. And I think there's something really important about educating our children about the dying process in a very ordinary way, that this is something that will happen to all of us, and we can all approach death in a very loving way. And I'm just going to put a plug in for one of my favorite movies, the way it displays death. It's the Cinderella movie by Kenneth Branagh. There are 2 moments in that movie that display death in the most beautiful way, if you want to see this. When Cinderella's mom dies, and when the Prince Charming, I don't remember his name, when his dad dies, and he climbs onto the bed with his dad who's dying. It is one of the most beautiful scenes that Kenneth Branagh put together to show dying in the context of a loving family. And I think we need to recover that image of dying with a family around the bed. And it doesn't have to be a hospital bed. It can be the bed that person has been in for their whole life. I think to normalize death for our children is a good education.
I totally agree with you, Thomas. Certainly, that's the goal that we've here in Georgetown done, is try to get patients back home. We have a great team of nurses and PSWs that look after them at home, and it is such a positive experience for the whole family. It used to be thought that, I'd not want to die at home, but I find a lot of patients now will accept that as a better thing than dying in hospital.
A number of audience members have sort of chimed in on a follow-up question to this, which is, can any of you provide a rough statistic on the accessibility of palliative care in Canada, like a rough percentage for patients, just off the top of your head? If not, don't worry.
The best data we have is that under 30% of Canadians who need it have access to any form of palliative care, and less than 15% have access to specialist palliative care when they need it.
Perfect, thank you very much. A number of people were wondering about the exact statistic there.
I think in rural communities, you'll see much less access to palliative care. And I think that may increase in time because we are getting physicians who are being trained in palliative care now. So it becomes a little bit different as the younger people come up. Hopefully they will take hold of dealing with their patients palliatively in homes and in the hospitals.
Yeah, I will just add to what Paul's saying is, so those are just like general population level statistics about the 30% and 15%, but really access to palliative care depends on where you live. Do you have a house? Do you have extended healthcare benefits? What's your diagnosis? Like people that have cancer have much higher levels of palliative care than people that have non-cancer. The rural and remote regions and other structural determinants of health, besides housing and poverty, for example, prison, if you're a prisoner, it all affects your ability to access care. So lots of people have virtually no access to palliative care, unfortunately.
Yeah, I think also, you know, as you mentioned, Leonie, the fact is that that people aren't aware that things like congestive heart failure and chronic lung disease can be treated in a palliative way as well. It's not just cancers. We need to be treating anyone who's looking at have a low health state and looks like they're going to pass away in the next year or so. We should be looking after those patients in a palliative way.
Just sort of continue with that conversation then. The next question that we can address is about the limited palliative care resources versus this growing accessibility of MAiD, especially following Bill C-7 this last year. And do you think it's possible for there to be greater access, a significantly higher access, ideally for all Canadians, to palliative care? And what steps can not only you as doctors, but we as just citizens take to advocate for these improvements and these much needed supports?
Yeah, so the Canadian Hospice and Palliative Care Association, as well as the Canadian Society of Palliative Care Physicians, have both been advocating for palliative care and other supports in living, such as home care and disability services, to be deemed essential services under the Canada Health Act, as MAiD has been deemed. So if a service is deemed an essential service, then provinces are required by the federal government to fund the service and make it accessible. So when MAiD was legalized in 2016, it was deemed an essential service, which means the provinces had to come up with a way rapidly to make it available and accessible to people who wanted it. Unfortunately, the same thing has not happened to all of those services, disability services, home care, and palliative care, to make it available and accessible. That's a whole further conversation about the implications of that in the context of MAiD. But you know, at a minimum, I think making those important services to support living with serious illness are critical to be made part of the Canada Health Act. So a lot of political advocacy. It would have been an easy thing for them to change during the C-7 legislation, which is what we were all advocating for, but we can still continue to press that. In fact, the United Kingdom has just made palliative care a required service for their National Health Service. So they're leading the way, and Canada can follow suit. So pressure on the politicians is good.
Okay, so next, let's further discuss MAiD. We sort of started by talking about palliative care, and now let's move our focus a little bit towards MAiD. This is a question that actually just came in from one of our board members, and it's that we know in Holland, Belgium, and possibly in other jurisdictions, terminally ill patients find themselves under more and more pressure to accept physician-assisted suicide or MAiD. And in your experience, have the same pressures begun to be felt in Canada, especially since the passing of Bill C-7 in this last year or so? Have you noticed that pressure increasing?
I think that I notice a little bit more sort of a concern about people or physicians discussing MAiD as a sort of an option to palliative care or to just other care. And that can be a bit of an issue. I think to some extent, some doctors feel that they have to talk to them about the alternatives. I think doing that in those situations is not a really good idea. I think the best idea really is to talk to them how we can care for them. And caring for them is the more important thing. If they bring up MAiD, and we then need to discuss, as Thomas said, where their fears are, what their problems are, what are the things that we can do to help them live their life rather than end it. So I think it's important, and I think people that are looking after patients who are dying have to be very careful about giving people the option to have MAiD, and that, because that, I think, gives them the thought that that's just as good as anything else that we can give them.
I would say that we've heard more reports from the disability community about, and this is in the media, so it's not my personal experience, that there have been more offers, or like MAiD is being brought up as an option, and the majority of the folks within the disability community do not support. They did not support Bill C-7, that they felt that making a disability a reason to become dead was discriminatory against their right to life, and perpetuated ableist views. And they have not much access to supports for living. And that has been something that's been amplified by the COVID-19 pandemic. And in fact, I will even just refer to a quote from the Minister of Disability Inclusion during the C-7 debates in Senate, who said that in some places in Canada, it's easier to get access to MAiD than a wheelchair. So imagine if you have few access to the necessary supports to help you in living, but that you're offered MAiD as a solution. And it does seem there's more media reports, but of course the media is often biased. So I think we don't have the data to direct us. There's not a lot of information that's come through, of course, yet since Bill C-7, and we won't have that level of data. Like, what was the reason that they had a not reasonably foreseeable death? Was it a disability or chronic illness or a mental illness with the underlying chronic illness? Like, that level of granularity is not going to be available in the MAiD reporting. So it's going to be very difficult to understand. All we know, like from the Ontario statistics, is the number of cases per month who were through which track of MAiD. So it's just really difficult. I would say, sorry, I will just add that I think there's a lot of pressure being put by MAiD lobby groups and MAiD advocates to require doctors to bring up MAiD as an option to all eligible patients. And many patients don't want someone, including the disability community has said this, someone to suggest they're better off dead, first of all. They find that as very scary, that their lives are being undervalued. Second, I think it can exert a subtle pressure. And again, like, we need to study these things, but we do know that patients have told us that they have requested MAiD because their trusted surgeon or their trusted oncologist recommended it to them as an option. And so, patients take the recommendations of their doctors very seriously. Like, we go to university for a long time. I did 17 years of university training to get to where I am. And, we do have expertise, and we provide a recommendation on what is in keeping with a patient's goals and is best going to meet their needs based on their particular illness. And so a doctor suggesting MAiD as an option could be the push that someone needs to choose MAiD when they wouldn't have otherwise. And I can give you countless examples, and so can my colleagues, of people who have specifically requested it because they were told by their doctor that they interpreted it as they could have really bad symptoms and they better get it. So.
Yes, and I think one of the things that I have heard also is it's we have to ask patients what their goal of care is, right? And what options they have. And so, but really we have to look at what the goal of the patient is, not what the goal of the system is. It's not about us, it's about them.
So Dr. Harvey Chachanoff, sorry, just wrote a fantastic paper. It was just published in the Journal of Palliative Medicine, and it's called The Platinum Rule. So instead of the Golden Rule, and I highly recommend everyone to read it. And it is about what we're talking about, just what you're saying, Paul, that how we best care for a person is in what they would want for themselves and how they see themselves in the world, not how we may place value judgments on how they might be in the world. And if we were in their situation, what we would want, right? And I think that's really something to take to heart and reflect on as healthcare professionals. And I really think everyone should read that paper.
Yeah, and it's not only us, it's the government. It's not, it's not what the government wants, right? Or what the government rules. I think it's what the patient actually wants, what their real feelings are. And it can't be influenced by us that way. We shouldn't be doing that. We can influence them in saying that we can take care of them as best we can.
I think the other dimension to bring up is the idea of safe spaces. I think this has been brought up before, but even though there is a move that MAiD be available and accessible everywhere, the reality is that a large number of Canadians want to be in a space where it's not available because they feel safer there. And I think that's not necessarily being recognized. I think a lot of people are advocating that everyone needs MAiD in every facility, in every place possible. And that's simply not a view that respects the diversity and kind of reflects the tolerance that Canadians expect. I think we need to build safe places where MAiD is not available because many Canadians want that space. And for people to feel safe in a place where MAiD is not an option, we should respond to that request and that need from a lot of people.
Thank you to all three of you for really coming together to answer that question. The next question is a question that we sort of put together after receiving a number of similar questions from doctors and nurses, many of whom are in attendance tonight, wondering how best to speak with a patient who has requested MAiD. And I think that one of the best ways to learn is through stories and sharing experiences. So I'm wondering if any of you are comfortable discussing some of your own experience in working with a patient who has requested MAiD and how you approach the situation, and if you can share any advice about having these types of conversations.
I think that's it's a fluid thing when you're going in to see a patient, and they've had a conversation about MAiD with another doctor. Because and what I tend to do is do a lot of listening, because my talking doesn't necessarily give them the answers, but my questions give them the ability to speak up for what they want and what they can have. And I certainly will tell them how I can help them, how I can get them through this, how I can help support them and their families, and how I can give them a safe place to stay. So whether that's in our palliative care unit or whether going back home, or just me being there on a daily basis to make sure that they're looked after and that they will be held by us and not let go and not disenfranchised. And I think that's an important thing for people to feel, because a lot of people who want MAiD or are looking at MAiD don't feel loved or supported or feel that they're going to have their symptoms treated properly. So I think we need to be their support for them.
Yeah, I think Paul mentioned everything I would have mentioned. The main ideas for me are really addressing unmet needs, and a lot of needs have nothing to do with medicine. A lot of needs have to do with companionship and recreation. This morning I was in with a group of my old lady patients who were bathing their dolls. So we have this amazing doll therapy program in our nursing home, and they're all bathing their dolls, right? Like they literally think these are their babies, these women with dementia, and they love their babies and they're bathing them, right? Like that is the type of creativity in rec therapy that allows people to live with joy, even in dementia in a nursing home, and I always love to see the creativity of a care team that is trying to find new ways of bringing people recreation and joy at the end of their life.
Yeah, I think I probably responded to this question during my remarks at the beginning that, palliative care comes alongside someone and seeks to understand what's underlying the request, and fully and sensitively explore what's happening to the person and what they're experiencing, and really, what they're worried about, because it is oftentimes fear-based, and sometimes education around what normal dying looks like and how palliative care can support a person through to the end of their life is often enough, and what the options are in terms of palliative care supports and what that looks like. So I think the challenge is that a lot of this work takes time. And time is not on our side now with the new legislation, because we've lost the 10-day reflection period. And many times the 10-day reflection period previously was waived anyway, but we do know from the Canadian government's own data that people changed their minds about MAiD when the 10-day reflection period was in effect. But it was removed without data to inform that it was necessary or making a difference. It was removed based on ideology. And so now we more commonly see patients getting MAiD within a day or two of their initial request. And that does affect our ability to provide our good care and our palliative care supports when palliative care is either not involved at all, which is a certain percentage, up to 20% of the most recent data we have of as much as we know about palliative care involvement, but it's most often involved very late, when it's 2 weeks before someone becomes dead through MAiD is not enough to have made a difference. And now it's going to be even less, because that was the data before C7. So, and I think I said this on a video before, but, unfortunately now sometimes a person's worst day becomes their last day, because we don't have the time or the opportunity to provide all of these dignity conserving care we know can make a difference, or even allow some time for the person to naturally come to change their mind, as we know from Dr. Chachanov's work, that desire to die fluctuates. And in other places, like in Australia, they're really seeing, as I think we're seeing here, that MAiD becomes a bit of a process. So it's very focused on the teams that don't really know palliative care that well may hear a desire to die, and it may be a request for information, an opportunity for information on MAiD and to talk to people about all their options, but it's actually followed through with a formal request for a MAiD assessment, rather than spending that time at the bedside and really making sure that those other supports have been put in place to address the issue, but it's interpreted as a request for MAiD rather than a desire for information. And so the process gets going. And I say that because that's what patients have told me, not because I think that myself. Patients have said that it becomes very much about a process, and it's very hard to stop the process once it gets started.
Thank you very much to all three of you. I think we're approaching the 1.5 hour mark of the lecture. So I think we're going to do one final question and then sort of wrap up the evening, if that's all right with everyone. And this final question comes from a number of the attendees this evening who are medical students or young doctors. And we're hoping to address some of their concerns with this question. It's sort of two questions in one. You can address both. You can address either end of it, or just young doctors or medical students in general. So the two questions are, what's the state of palliative care training that you're finding with young doctors and medical students? And the second question is that some medical students are interested in pursuing palliative care as a specialty, but are uncomfortable administering MAiD. Is that something they can avoid in both training and in practice?
I think Dr. Leonie, Dr. Herx knows the answers to all these questions.
Yeah, so go ahead, Paul.
I am encouraged by the younger students that we have in our office who have been getting palliative care training, and the fact that palliative care training will influence the way that we talk to our patients. And that's really important. And that will happen not only in palliative care, but in family practice and all the other services as well. So I think overall, I think that's going to help. A palliative care doctor providing MAiD seems very sort of dystopian. I think it just doesn't sound like something that we would see happening. The services for MAiD are separate from those of palliative care. So I don't think because really the two don't match. We don't offer people care and compassion and the best sort of training that we can give them to make them better, and do MAiD at the same time. That would be, I think that would give the patient a scary ride, if you know what I mean, because they don't know which end is going to happen.
If I may, I can speak to the national training standards for palliative medicine specialty programs, but I can also speak to what I know about integration of palliative training within other specialties. So family medicine has made palliative care a core competency of a family physician. So the residents who come through palliative medicine now, family medicine, they do get opportunity to have training and develop core competencies and skills in palliative care, which is amazing. And that wasn't the case, 10 or 20 years ago. So we're very lucky. And we have, this Canadian Society of Palliative Care Physicians has a recommended competency document for all non-palliative specific specialties for what they should achieve for palliative care. And we're not to the point where that's been integrated into all the other specialties. But I just wanted to give a shout out to family medicine because they've really taken ownership of palliative care as part of holistic family medicine. And you can see that because we have 2 specialist palliative care training programs in the country. One is an enhanced skills program through the College of Family Physicians, and we cannot keep up with the numbers of trainees applying to that route. We have so many outstanding applicants every year who want to do that extra training and see the value of providing that whole person care, that we just don't have the spots, even though we have like this training spots, even though we have the need for more of the people doing that type of care. And we have a new 2-year program through the Royal College across the country as well. And in both of those programs, providing assisted death and training assisted death is not part of the training. As I described earlier, hastening death is actually not part of the discipline of palliative care, and that is consistent internationally and nationally. But of course, like any physician can choose to build something onto their practice that's separate from what they do. They could practice sports medicine or cosmetic injections, or, so there are certainly some palliative care physicians who have chosen to practice MAiD as well, but it is a separate practice.
I'll just add that I think we're now at a stage where learners need to look for preceptors that are a good fit for them. And so it's not necessarily about finding a specific program in a specific city. I think you're now looking on a more personal level at which preceptor would I like to work with? And that's how you maybe shape your decision for your training program, whether it's specialty palliative care or family medicine. So keep your eyes out for the preceptors around you that would be good mentors for you.
Thank you to all 3 of you. And I think with that question, we'll conclude night 2 of the deVeber Institute's March lecture series. I want to extend my immense gratitude to the 3 doctors who joined us tonight, Dr. Leonie Herx, Dr. Paul Zeni, Dr. Thomas Bouchard, for sharing so openly and coming together to thoroughly address all of tonight's questions. Thank you, and thank you very much.